to everyone. Today's topic is hormone therapies in gynecology. It is a vast topic, but I will make it as short as possible, okay? And coming to the topic proper, hormone therapies, you know, if you have to use it very systematically and in a very casually, I mean, you cannot take it as casually, because if you give one therapy, you should know how to treat what sort of patient, or the indicated patients only have to be considered. You cannot use it haphazardly, because that may make the patient or go for some other surgeries also, okay? So we'll start with the scenario. Mr. VB, she is 58 years. She came to the clinic with postmenopausal bleeding for 2 weeks. Okay, just remind that she's 58 years. She had postmenopausal bleeding for 2 weeks, and she looks a little bit upset and depressed. Her menopause was at 51 years, and she experienced severe hot flushes and mood swings at that time. That means at the time of 51 years. And she consulted a local doctor who prescribed her estrogen tablets. Okay, no progesterone was given. She was not counseled regarding the duration, how long she has to take the tablet. Okay, and the need for a follow-up was not given to her, and the risk or benefits of the treatment was not explained to her. And then BB found that after the medication, she was very much happy, she was very effective, and she continued to take it for 7 years. Then she noticed this vaginal bleeding 2 weeks ago, and she consulted a gynecologist, and she was evaluated and diagnosed to have endometrial cancer due to the unopposed and long-term estrogen therapy. So I just want to mention in this that a long-term HRT is not at all described in any of the patients, okay? You can just give her for a short term till her symptoms improve. You have to stop her, okay? That's the idea behind the hormone therapy. Okay, we'll go to the as you know, the normal reproductive function is always dependent on hypothalamo-pituitary-ovarian axis, because the control is in the hypothalamus, okay, and then the end organ is the ovaries. So regulation is through these hormones. Any imbalance can cause all these symptoms, or any imbalance can cause any upset in the ovarian function, and the patient can present to you with so many symptoms. So the common gynecological disorders caused by these abnormalities in the hormone production can be treated by administering these hormones or their agonist or antagonist, okay? And malignancies of the genital tract can be treated by hormones, are those malignancies which are estrogen or progesterone receptor sensitive malignancies. So coming to this hormone therapies, oral contraceptive pills and the HRT in the postmenopausal woman are the important uses of hormones in gynecology, okay? And while giving this hormone therapy, the side effects, we have to know the contraindication, which patient have to have this therapy, and the patient have to be made aware of the side effects. That's a very, very important point regarding the hormone therapy. And before starting any hormone, please evaluate her. That is a pre-evaluation and a counseling for these precautions and the side effect. And most important is follow-up is a very important thing for which is missed by the gynecologist as well as the patients, okay? So coming to the gonadotrophin, you know gonadotrophin, that is Gnrh, which is released from the hypothalamus. It is a decapeptide. It is released in a pulsatile manner by the hypothalamus, okay? And the continuous administration of Gnrh will lead to initial transient gonadotrophin stimulation. There is an arrow which is very light to be seen. And then it causes a prolonged down regulation, that is desensitization of the Gnrh receptors in the pituitary, and there is a marked decrease in the gonadotropin secretion. Gonadotropins are FSH and LH. So this is the basis in the chemical use of Gnrh analog. Gnrh being Okay, GnRH analogues are actually, the GnRH is a very short-acting drug which it is not recommended, okay, and it is inactivated by the gut. That's the reason why the analogues are invented, and the analogues are actually enhance the potential, but it synthesize and it is the duration also is longer than when compared to the natural GnRH, and that's the reason why analogues are used for clinical uses, okay? And these analogues have prolonged and sustained action and tend to suppress the gonadotrophin. So I told you before, no administration orally, because when it enters the stomach, it is inactivated. These are the usual preparations: buserelin, naphthalein, goserelin, and leuprolide, you know, the fourth drug. It's the commonly used drug, okay? The dosage is 3.75 milligram. It is IM dose. It can be given daily also, mostly for DUBs, and for myomas, we use 3.75 monthly. That is every 21 days we use this dosage. And the rest of the drugs are intranasally. It is a buserelin, naphthalein is always available as intranasal sprays, okay? And you give much importance to the leuprolide because that is the one which is being asked for the viva, because we have the Modulators, okay? And the therapeutic uses of GnRH analogues. The pulsatile administration is for hypothalamic amenorrhea, then for infertility, for downregulation of ovulation induction, that is prior to ovulation induction, you start with the GnRH analog, make it downregulate, and then you induce with gonadotropins, okay? And daily or monthly administration is for central precocious puberty, and for endometriosis, we are using it for those patients to suppress, causing a menopausal effect for these patients, okay? And uterine myoma, if the myoma is a bigger size, just like 16 weeks, and you want to reduce the size, 40% decrease in the size can be expected by giving leuprolide for 3 to 4 months, okay? So that you can go for a laparoscopic resection than doing a laparotomy for a myoma. So you can reduce the myoma and take it through the laparoscope, okay? Then for abnormal uterine bleeding, for making the endometrium very thin and making the patient in a pseudo-menopause stage, and thus causing atrophy of the endometrium, and thus bleeding can be stopped, okay? She can be brought into an amenorrheic stage. Then preparation of the endometrium for transcervical resection, that is when you when you decide a patient, especially for AUB, you start to decide on a say resection of the endometrium. You have to make the endometrium, you have to make the endometrium thin. So for that, you give first leuprolide and make the endometrium very thin, and then you put the patient on a transection, resection of the endometrium, okay? Then hormone responsive breast cancer. You know, some estrogen receptor positive breast cancers can be treated with this, okay? Then cryptorchidism and prostate cancer in males also, you can use this. Then the side effects. You know, I told you before that it causes a pseudomenopause. Side effects just like menopause, that is hot flushes, vaginal dryness, insomnia, dyslipidemia, and decrease in the bone mineral density, okay? So that's the reason why you have to substitute. Mostly we confine the patient to less than 6 months of therapy, and if you're deciding the patient to give it for a longer duration, that is more than 6 months, you have to add back therapy. That is, add back therapy is giving a low dose estrogen or OC pills, okay? And then you may make the patient prevention for osteoporosis. That's add back therapy. And when estrogen is contraindicated, that is in cases of venous thromboembolism or something like that, you can give Tibolone is given. This is add back therapy. This is a very short note question for you. And add back therapy is nothing but the longer the duration of therapy you have decided, that is more than 6 months, you have to put the patient on a low dose estrogen or an OC pills, that is again a low dose, or you can put her on SERMs. Then coming to the antagonist, that is Gnrh agonist we have talked about, and antagonist is also again, it is again a synthetic peptide. It is developed to overcome the disadvantages of agonist. That means longer duration, takes longer duration for the agonist. But whereas this one takes faster action, and they do not cause the initial stimulation of gonadotrophin. They do hyperstimulation is not there. So you cannot, if you give Gnrh antagonist to some extent, you can prevent OHSs. Okay, and these are the antagonists which are available, and Cetrorelix is available in our place, and it is given subcutaneously, and this is mostly used for preparing the patient for an ART, that is artificial reproductive techniques, mostly IVFs. And coming to gonadotrophins, you know, gonadotrophins are produced from the pituitary. The two gonadotrophins are FSH and LH. And FSH, you all know, it stimulates the follicular growth and production of estrogen, okay? And coming to LH, it triggers the ovulation. You know all this just I want to cover it up, that's all. And it stimulates the progesterone production, sustains the corpus luteum, and if the patient has an impairment, she became fertilized ovum, it supports the implantation. So these are the functions of LH. These are the preparations. Again, I think I have covered this slide. It's a repetition. Okay, coming to FSH, FSH is extracted, it is actually extracted from the postmenopausal woman, the urine of postmenopausal, and it is known as menotropins, and this contains equal amount of FSH and LH. Sorry. So recombinant FSH using DNA technology has been produced, and these are the ones which are used now. And coming to LH, actually the LH always mimics an HCG. So this is being extracted from pregnant women. I mean, these menotropins are extracted from postmenopausal woman, whereas the HCG is extracted from the urine of a pregnant woman. And recombinant forms of LH are under trial, and shortly it will be in the market. Okay, these are the gonadotrophins which are available. Menotropin is the brand name is Pregnenolol, and it is the route of administration is IM, and the dose is, it is always in the international units is available. And the recombinant one, that's the third one that is available in our market, again Gonal, it is known as Gonal, and it is mostly used for IVF patients. And coming to the LH, that is the HCG, that is Pregnyl, it is again available, but the dose is thousands. It's used in 1,000 to 5,000 units, and it is given just prior to ovulation. It causes an LH trigger or a LH surge and causes an ovulation, so that the ovulation is under the control of the in IVF patient, doctor. Okay, so we want to control the LH and control the ovulation so that we can do a elective ovum pickup. We decide to give the LH at after 36 hours of this surge. Okay, so this is how it. The main side effect is ovarian hyperstimulation syndrome. Coming to prolactin inhibitors, the prolactin again is produced by the pituitary. It plays an important role in preparation of the breast for lactation, and the uses of prolactin inhibitors are in conditions, as you know, it is hyperprolactinemia, prolactinoma or adenoma of the pituitary, then suppression of lactation, and in severe cases of mastalgia also you can give, and infertility, hyperprolactinemia causing an infertility, where the prolactin may be raised and there is no other cause for infertility, you can give and bring the prolactin level to normal. Okay. And these are the ones which are available. I think you know it. Only thing you need it for the Viva. Bromocriptine 2.5 to 7.5 milligram. It can be given orally or vaginally daily. And the next generation is the Cabergoline, which is widely used again. It is in the dose is 0.25 to 0.5. The main advantage of this Cabergoline is it can be given only twice weekly. You can give, and it's an oral dose. And this is the most preferred one which we have. the advantage of cabergoline is it's a longer half-life, longer selective receptor activity, and fewer side effects when compared to bromocriptine. And the dosage, as I've told you, it needs only to be given twice weekly. The drug of choice for hyperprolactinemia is now considered to be cabergoline. And the dose, again, I am repeating, is 0.25 milligram. You give twice weekly initially to start with, and then gradually you can increase to 1.5 to maximum dose of 2. Okay, this is a very good drug. The side effects are very minimal when compared to bromocriptine. The patients tolerate it, even though the side effects of all general prolactin inhibitors are nausea, vomiting, headache. Postural hypotension is a very important side effects of bromocriptine, but when compared to cabergoline, it is less. Nasal congestion and CNS effects, hallucination, psychosis, and insomnia. Okay, next drug is the estrogen, which is being very carefully given drug, okay, but a very useful drug. It's again, as you all know, it is a steroid hormone produced by ovary and the peripheral tissues, that's the adipose tissue. The 3 forms or the 4 forms are actually available: estrone, estradiol, estriol, and estratrol. Okay, these are the 4 ones available. I have just entered only 3 forms. They have a physiological action on several organ systems. They act on the reproductive organs, and also they are very much concerned with the metabolism also. The synthetic form is available for use. Micronized estrogens are not available. It's still available, but it is not preferred use. It's not that good when compared to the synthetic progesterones. Okay, then the estrogen receptors, as you all know, it acts through alpha and beta receptors, and these hormones act by binding to these receptors. Coming to the physiological uses, there are so many uses of estrogens. When we give for the viva, you are able to tell 2-3 uses. Okay, at least you have to know 5 uses of this estrogen, because this is a very important question which can be asked for viva. The pubertal development of the female or genital organ, you know, the breast, then the genital organs need the effect of estrogen. Then the pubertal growth spurt in the females and the development of secondary sexual characters, especially the breast development. Then the suppression of the pituitary gonadotrophin production and stimulation of LH surge also need this estrogen. And you know, the endometrium, this estrogen has a proliferative effect on the endometrium. That is a very important effect of this. And then only the progesterone act on the proliferative endometrium and make it into a secretory endometrium. Okay. And this has a very much effect on the bone mineral density, and it prevents osteoporosis to some extent. And then carbohydrate, protein, and lipid metabolism. That means there is an increase in the fasting glucose, increase in the hormone binding protein, so that hormones are not that freely, very less when compared to this. Then increase in the HDL. Increase in HDL and decrease in the LDL, which is a very beneficial effect, okay, and increase in the coagulation factors and fibrinolysis. That's the reason why when you give HRT, you have to be very conscious about giving, because there is an increase in the coagulation factors, which can lead the patient to DVT and other thromboembolic episodes, okay. Then the preparation and dosage, it is absorbed from the GIT, from skin and its vagina. So intramuscular available, or on oral administration, it is metabolized by liver to estrone and estradiol glucuronide. That is a very less weak estrogen. So what happens is the effect of this estrogen is that not that much appreciated. So this is called as first past effect. So you have to know that. Then coming to the natural ones, the conjugated equine estrogen and estradiol valerate. These are the 2 natural estrogens which are available. As the name suggests itself, the conjugated equine is taken from the horse, okay. And the other thing which is widely used is the valerate, estradiol valerate, which is being used for vaginitis and for postmenopausal dryness and all. These are the 2 natural forms which are available. All other estrogens others are synthetic estrogens. Just keep in mind that which is available over the counter is always a synthetic. The other ones are Premarin, it's available as Premarin and all this, conjugated natural ones. Others are available as ethinyl estradiol in various strength. Okay, it is mostly used for development of secondary sexual characters, especially when you take a case of Turner syndrome, where the girl is only 11 years old and there is no breast development. You can give a short term of ethinyl estradiol and make the breast enlarge, and then you can hardly stop away with that. Okay, and it is always, you know, it is a component of OC pills also. And coming to the conjugated equine estrogen and 17 beta estradiol are used for HRT. And micronized estrogen, I told you before that it is not in use, even though it is available, it is not being used. And the IV preparation, I told you, it is a very good drug when the patient comes with a heavy bleeding, where you cannot stop the bleeding and you find the patient is in a shock stage. You can give an IV preparation and high dose of estrogen and you can arrest the bleeding. And transdermally and vaginal rings are also available, which are used for hormone replacement therapies. These are the preparations which are available. It is available in the trade name of Gnrh. It is various strengths are available. Depending on the need of the patient, you can decide on the dose. That is very small dose. That is a 0.1, 0.03, 0.05. It is available. It's in the milligram unit and it is daily. You can give it. And the important drug Premarin, that is conjugated equine estrogen. You all will be familiar with the name Premarin. It is again available in various strength, and mostly we stick on to 0.625 milligram. It is always being given for postmenopausal women, or when you want to prepare the patient, or you find estrogen, that is when the endometrium is atrophic, or you get an atrophic vaginitis or endometritis. In such cases, you want to build up the endometrium, you can give a short course of Premarin. Then the synthetic estrogen which are available are also available in various, that is a tablet form. That is again micronized estrogen. I came to know that this is the drug micronized estrogen. It is esterase but is not being no longer used. And the transdermal and other patches are being recommended nowadays. It is available as Estraderm and it can be stick to your skin, and she can have all this for a weekly. That is, she can use it only twice weekly. Very good effect. And gels are also available. It can be applied in the vagina and it gets absorbed. Okay, and intramuscular, it is available as depot. Coming to the preparation, the continuation, conjugated equine estrogen, I told you it is available in the tablet form as well as in the intravenous form, which can be given for a heavy bleed. The vaginal, that is the creams which are available in India also, we give it for a short term. It can be applied to the vagina once daily because it very well absorbed through the mucosa. Then the conjugated estrogen creams are available, Premarin creams, which can be given for a prolapse patient where you want to increase the blood supply, or you want to prepare the patient before vaginal hysterectomy. You can give a local application of these creams and make the vagina a little bit thicker so that you can avoid bleeding. And vaginal rings are available, but is not available in India, only in outside countries. Okay, and Vegifem vaginal tablets are available. Implants are also there, but is not available in India. It can be changed every 3 months. Okay. The indication, you know, it is a very important indication because in the exams, mostly 2-3 indications will be asked, and you have to be thorough with that, and how to give also have to will be asked. Okay, so as you all know, the OC pills, the various doses, low dose pill, high dose pills are available depending on the ethinyl estradiol dose it is used. Very low dose pills have very low doses, 0.1 milligram, like that, 0.01. Okay, and these are the drugs which are used for postmenopausal postmenopausal hormone therapy, ethinyl estradiol in various strengths. It can be given as oral or patch or gel or as implant. Okay, and before I told you for Turner patient, hypogonadic patient, hypogonadotrophic hypogonadism or partial androgen insensitivity, when you find the patient has a very small breast and she wants to have adequate breast development, you can put her on the ethinyl estradiol oral tablets for a short time. Okay, and for abnormal uterine bleeding, when the bleeding you find it is torrential and you want to stop it, you can give a high dose of estrogen. Like that you can use it. And for vulvovaginitis in children where it is intractable, a local application of vaginal cream for 2 weeks, that is every weekly twice for 2 weeks is only needed, and she gets that is because of estrogen deficiency, atrophic vagina, you can just locally apply that. And for urogenital atrophy, especially in postmenopausal, you can use vaginal creams. And all these, mind you, it is a short-term course. The patient, if not counseled regarding the longevity of use, she will continue to use for long term. And you know the maximum absorption can have through the vaginal mucosa, she can go for vaginal endometrial thickness, and she can go for hyperplasia or atypia. Okay. Side effects, you all know the side effects you have to know in the oral. Nausea, vomiting, very much intolerated by the patient. Breast tenderness, migraine, thromboembolism, very important one. The patient have to be made aware of all these side effects. Otherwise, you will miss the patient. Okay. Endometrial cancer and breast cancer due to unopposed use. So you have to call up for these patients for every 6 months follow-up. Then stroke, hepatic adenoma are the other complications. Coming to SERMs are selective estrogen receptor modulator, because this estrogen caused so much trouble for the patients because there was not adequate follow-up. The side effects varies from patient to patient. So many cases of thromboembolism and other lipid abnormalities and heart disease were reported. And there was a study regarding the estrogen therapy, and it was not to be fulfilled because of all these side effects, and more of breast cancers was also seen. The study, it was a randomized controlled trial, and it was stopped, okay, because of so many patients went for all these complications. Then the decision for another drug, then came the drug is selective SERMs, that is selective estrogen receptor modulators. It is a non-steroidal, and the word itself tells you that it is selective in action. That is, it has an estrogen-like action on bone, brain, liver, and it has an anti-estrogen action on the breast and endometrium, and it reduces the LDL level and also triglyceride, having a beneficial effect on dyslipidemia. Okay. And these are the SERMs which are used nowadays. Tamoxifen, you all know, it is a drug which is being given for breast cancer and for gynecomastia also. Raloxifene, and a very excellent drug for postmenopausal osteoporosis, where you don't have to give the patient on estrogen. You can put her on raloxifene, especially those patients who have a family history of osteoporosis, or you find that this patient has a less bone mineral density. You can put her on long-term raloxifene therapy that is available as capsule 60 milligram, and also for breast cancers. Ormiloxifene is another drug. It is available in the name of Saheli. It is a contraceptive, and it can be given for abnormal uterine bleeding where it causes endometrial thickness, reduces the endometrial thickness. And the other drugs are available but not well used. Okay. Coming to the side effects of SERM, which has very less side effects when compared to the other drug. It causes hot flushes, but less when compared to the other drugs. Okay, the vaginal dryness, the endometrial polyp and hyperplasia are another complication of tamoxifen. And the patient is on tamoxifen, she has to be called up every 6 months to have an endometrial study. That is, the endometrial thickness have to be noted to avoid this hyperplasia and polyps. Okay, and then venous thromboembolism is at another one, but rare complication. We dealt with the estrogen. Now coming to the anti-estrogens. Anti-estrogens have action on all tissues. Unlike the SERMs or other things, this acts on all tissues. Clomiphene citrate is another drug which is familiar to you, and fluostrant is another one. It inhibits the negative feedback inhibition of Gnrh at hypothalamus. That means it competes with the estrogen receptor and make the estrogen free, and it causes a high stimulation. It causes a negative feedback effect and induces an ovulation. Okay, and usually administered from second day of the menstrual cycle to 6 days. That is the 4 days you can give her on this, and it binds to estrogen receptors on the hypothalamus and prevents the estrogenic action. The pulsatile secretion of Gnrh secretion with increase in the FSH and hence ovulation. It's a very important and commonly used drug. Okay. And the clinical uses are an ovulation, especially for polycystic ovarian disease, and unexplained infertility. You can induce ovulation, that is called a superovulation, and the patient might conceive after a single stimulation itself. And for patients or males who have less count and pre-testicular you can use around stimulation with FSH and cause spermatogenesis. Okay. And the side effects, the clomiphene citrate for a ART case, it causes multiple pregnancy, or it can cause ovarian hyperstimulation. And for others, it can cause hot flushes, blurring of vision, abdominal discomfort due to hyperstimulation, causes nausea, vomiting, multifetal pregnancy, luteal phase defect because anti-estrogenic action, it causes the cervical mucosa thick, which delays the sperm penetration, and again it causes the endometrium very thin, and in ART you have to substitute with a small dose of estrogen for 5 days, like that. Okay. And for a prolonged use, that means if you are using the patient or putting the patient on clomiphene citrate for more than 1 year, it causes ovarian scarring and it can lead to ovarian cancer. So always don't use clomiphene citrate for more than 6 months. You have to have an interval between treatments. Okay. And ovarian hyperstimulation is a rare complication. Fulvestrant is tamoxifen-like action used especially for breast cancers, and it is administered monthly as IM dose depot. Then again, coming to estrogen inhibitors, that is aromatase inhibitors, just I want to have this physiology. How this aromatase acts is androgen is always converted to estrogen by this aromatase enzyme. And this enzyme block or aromatase inhibitors block this conversion. So this is the pathophysiology behind using this aromatase pharmacology. Again, using this aromatase inhibitors. There are 2 types of inhibitors, steroidal and non-steroidal, type 1 and 2. I think this is not meant for you, but for completion's sake I have included. This is all meant for only PGs. But the drug coming under the type 2, that is non-steroidal, can be asked for VIVA, that is letrozole. So the clinical uses for postmenopausal breast cancer can be used as a first-line therapy or a second-line therapy in recurrent, or for preventing disease in the contralateral breast, or it can be given as a neoadjuvant therapy preoperatively. And this is more widely used, this letrozole, for ovulation induction. Previously it was not approved by FDA, but now FDA has approved and it is being widely used because why it is more preferred than CC, that is clomiphene citrate, is because it less of OHS is seen, and another thing is the endometrial thinness is being avoided by this aromatase inhibitors, and it can be used for reducing the size of leiomyoma, and for endometrial stromal sarcoma can be used, congenital adrenal hyperplasia, and short stature and gynecomastia. Preparation and dosage, it is available as 2.5 milligram tablet tolerated orally. The side effects are less, but still these side effects have to be noted. The patient can present with arthralgia, multiple swelling, arthritis, dyslipidemia, vaginal dryness, coronary artery disease. So be careful in patients who are prone for that, and osteoporosis and long term. Okay, osteonecrosis of jaw is also another complication. Coming to the progesterone, it's a very important drug because progesterone are very widely used hormones, where for cases of dysfunctional uterine bleeding or AUB, left and right, you see the doctors using progesterone and the patient lands up with heavy bleeding. So if you are not correctly using the type of progesterone and not correctly using the progesterone for how many days or not, the patient will land up in trouble. Okay. Suppose take for consideration the endometrium. That's the reason why I always study the endometrium before starting progesterone, because there is no use of giving a progesterone when the endometrial study shows it is a secretory endometrium. Okay. The causes may be something other than hormone deficiency. Only for bleeding where the endometrial study shows proliferative endometrium, then you have to consider progesterone, because while giving this progesterone, the unopposed effect of estrogen can be stopped by this progesterone, and the bleeding stops. So always very much give particular, you take a history, detailed history, always study the endometrium and then only start the patient on progesterone. Okay, or you may miss this, or the patient will be, you're treating a patient who may be an initial starting with a endometrial cancer. So always be careful by starting progesterone. It is a very good drug when used very systematically. Progesterone, it is a naturally occurring hormone secreted by the corpus luteum and the placenta, and you all know it is rapidly metabolized by the liver. It is not that effective while using the orally because due to first pass effect, so it is usually parenterally given or vaginally it is preferred. Progestogens. These are obtained from plants and animals. These are otherwise known as phytoestrogens. Okay, progesterone-like action. Then progestins are always synthetic progesterones. Okay, and the classification according to the time sequence it was introduced. There are 4 generations. 1, 2, 3, and 4 generations are being used. Okay, coming to this progesterone, the micronized progesterone, that is the sustain. We usually see it in the trade name sustain. That's a micronized progesterone which is widely used. Okay, and coming to C21 steroids, megestrol acetate, steroid isomers. The next is dihydrogesterone. Dihydrogesterone is available in the trade name as Dufastone. That's also very good progesterone, natural progesterone, which can be given for luteal phase deficiency or in IVF patients who have to need a support for the corpus luteum. Okay, coming to pregnanes. That is the medroxyprogesterone acetate, which is being widely used. Okay, that is available as MPA, which we use for AUBs or progesterone deficiencies. Okay, then coming to E strains, a very important drug, 19-nortestosterone derivative, so a little bit of androgenic action. So very much known for the hemostatic effect. And Primalute, it's available as Primalute N. Okay, norethisterone. Very much, if a bleeding patient comes, you study the endometrium, put her on Primalute, and bleeding suddenly stop, provided it is due to progesterone deficiency. Then another one is guanines, that is LNG. LNG is another very important drug. It is available as IUD, as implants, and also as an emergency contraception. And next is the neoprogesterone, desogestrel, gestodin, or gestimatal. Okay, coming to spironolactone, again a very important drug. Androgenic effect is there. Very good drug for hirsutism and acne, and other progesterones available are dinochest and normogestrel. Okay. Then coming to this physiological and pharmacological action of progesterones, Progesterone, you know, it is very much important for the glandular development of breast. That is, it increases the mitotic activity of the breast, okay? And again, I told you, it causes a secretory change in the endometrium, very much needed. It causes deserialization of the endometrium and always promotes implantation, and it's very important for maintenance of pregnancy. And the changes in the cervical mucosa makes the mucosa very thick and just prevents sperm penetration, so it is important in the family planning. Then suppression of Gnrh pulse, then glucose intolerance, and causes an increase in the LDL and decrease in the HDL. This is a very bad effect. This is not to be recommended for dyslipidemia patients. These are the ones which are available. It is available in various forms, that is patches, implants, rings, and available. Ring is not available in India, and Implanon is a subdermal application. It was an ICMR study. It has been completed and a very effective one. And coming to Levonorgestrel, that is an intrauterine device, very effective. It is available in the name of Mirena. Coming to the clinical uses, it's always used with estrogen. I told you it can be used for unopposed estrogen, so always combined OC pills can be used, especially for postmenopausal hormone therapy. Or it can be used only as, that is a progesterone only pill, especially for breastfeeding mothers. It is available as mini pill, or it can be used as a depot, that is MPA, it is Provera, depot Provera, you are all familiar with that. Or it can be used as implants or intrauterine devices. And this is the very important drug for emergency contraception, which will be asked for the exam again, VIVA. LNG, it is Levonorgestrel. It is to be given immediately or within 72 hours of contraception. It acts very good for the contraception. I told you for abnormal uterine bleeding, the norethistron, that is it has an androgenic effect which causes a hemostatic effect. When the VIVA, if it is asked that which is the hormone for, can be hemostatic hormone, immediately your answer have to be norethistron or trimalute, okay? Then for recurrent pregnancy loss, you have to support the corpus luteum. By that, the best drug is micronized progesterone. All these preterm labor, luteal phase, endometriosis, endometrial hyperplasia, and advanced endometrial cancer, you have with this progesterone sensitive receptor, you can put her on progesterone. And another very important and widely used is postponement of menstruation. Norethistron is to be used. That means it causes a high level effect for progesterone, and then when you suddenly stop it, it causes withdrawal bleeding. Postpone of menstruation is widely used. Okay, the side effects are nausea, vomiting, mastalgia, sodium retention. Very important side effect is water retention and weight gain, and worsening of the hypertension. So very careful in using in hypertensive patient. It can to some extent cause depression and irritability. Dyslipidemia, I've told you, thromboembolism to some extent, and prolonged use can cause breast cancer and osteoporosis. Okay. Coming to the anti-progesterone, the widely used drug which is very important for you is mifepristone. As you all know, the uses of mifepristone is for termination of early pregnancy. If you want to terminate the pregnancy within 49 days of pregnancy, mifepristone can be given because it is an anti-progesteronic effect, and it causes cervical ripening, and it can be used in the dose of 50 for endometriosis, and it causes uterine myoma into a smaller size, can be used for long term for uterine myomas. Emergency contraception, it can be used. Breakthrough bleeding for the depot MPA, and leiomyoma, breast cancer, and other uses are this. Okay. Then coming to the side effects, very important thing, nausea and vomiting. That's the reason why you have to give this mifepristone early in the morning, empty stomach, but you should not make the patient vomit. You have to give an antiemetic along with this mifepristone. Okay, that's a very important factor. It can induce uterine cramps, it can cause cardiac failure and adrenal insufficiency. Androgens, coming to androgen, the androgen preparations which are available are testosterone estate and alkylated androgens, and among these, danazol is the most important for you. Danazol is widely being used because of its effect on various conditions. The uses of danazol, I just concentrate on danazol alone. It can be used orally for endometriosis. The dose is a little bit high, that is 600 to 800 milligram per day, and it can be used for heavy menstrual bleeding also. The dose is 200 milligram per day. It can be used for intractable mastalgia with a low dose, that is 50 milligram per day. Okay, and for emergency contraception also it can be used. The dose is 200, and it is available and vaginal application, which can be used for endometriosis. The side effects of danazol, because it is an anti-androgen, it can be the side effects of postmenopausal symptoms, that is causes amenorrhea, it can cause hirsutism, it can cause acne, oily skin, depending of the voice, weight gain. So it is a drug which cannot be used for long term. Coming to anti-androgens, the imidazole and the ketoconazole, which is no longer used because of the hepatotoxicity, and the inhibitors testosterone, you know, among this spironolactone is the best important drug, and 5-alpha reductase. These are the drugs which are anti-androgens, which are widely used. And coming to this cyproterone, I just want to concentrate on spironolactone. Usually it is an aldosterone antagonist. It suppresses the testosterone biosynthesis and by inhibiting the 5-alpha reductase, okay? And it is the very important drug for treating PCOS with hirsutism and acne, okay? These are the drugs, and the dose is 50 to 200 milligram daily you can give, and it is a very important drug for contraception also. But the most important side effects is menstrual irregularity, mastalgia, and another very important drug where you have to have contraception along with that. That means ethinyl estradiol have to be added. Why? Because if the patient becomes pregnant and suppose it is a male fetus, there can feminization of the male fetus can take place, okay? Feminization, that is a very important, and some cases teratogenicity also. So if the patient conceives on spironolactone, the pregnancy have to be terminated. Okay, I think I have finished this topic. Okay, thank you.
Thank you, ma'am.
I think a few drugs are important for your viva. Other than that, I think a short note can be asked for HRT. HRT short note can be asked. Otherwise, a short note regarding the clomiphene citrate or agonist, all these things can be asked. Progesterone can also be asked for short note, but the viva, all these medications will be asked. Okay. Any more doubts? Anything to be cleared? No. Shall we stop?